Welcome to the Grenz Zone, dissecting dermatology differently. Here is your host, Dr. Logan Kolb.
All right, welcome back, friends. In this episode, we will continue our discussion of papulosquamous rashes by going over Mycosis Fungoides. Remember, we have 5 main reaction patterns: papulosquamous, eczematous, vascular, dermal, and vesicobullous. We further break the first category, papulosquamous rashes, into 5 broad categories. 1. Psoriasiform, which resembles the prototype psoriasis. 2. Pityriaciform, which resembles Pityriasis rosea. 3. Lichenoid, resembling Lichen planus. 4. Annular, such as Tinea corporis, otherwise known as ringworm. And then 5. Erythroderma, which has many causes. So we will continue our discussion of the first category, the psoriasiform rashes. We have previously discussed psoriasis and seborrheic dermatitis, and will now be talking about Mycosis Fungoides. Before we start, I'll quick throw in our disclaimer.
This episode is meant for educational and informational purposes only and should not be used as a substitute for medical advice, diagnosis, or treatment. Nor does this episode represent the views of Orange Park Medical Center, Olmsted Medical Center, or their affiliates.
So, Mycosis fungoides, often referred to as MF, is a very daunting condition, both for patients who have often had it for years before they get their diagnosis, and also for medical students and residents trying to learn about it and put it in the larger context of the many cutaneous T-cell lymphomas. So I want to start by building a framework for thinking about cutaneous lymphomas, and then go on to our discussion of classic Mycosis fungoides and its progression through patch, plaque, and tumor stages. Let's take a very basic look at lymphomas. They're named as such because they typically start in the lymph nodes, where they can be put into 2 categories. One category being Hodgkin's lymphoma, and the other being the various B and T cell non-Hodgkin's lymphomas. These lymphomas can also start in the skin, with primary cutaneous Hodgkin's lymphomas being extremely rare, whereas primary cutaneous non-Hodgkin's lymphomas cause nearly all of the primary cutaneous lymphomas that we'll discuss. For these primary cutaneous non-Hodgkin's lymphomas which start in the skin, 80% are cutaneous T-cell lymphomas, also known as CTCL, whereas 20% of cases are cutaneous B-cell lymphomas that we also call CBCL. So forget CBCLs for now, as we may discuss it in a different episode, but let's focus on CTCL, or cutaneous T-cell lymphomas. There are several types of CTCL, so consider it an umbrella term. We lump CTCL into 3 main groups. The first group consists of Mycosis fungoides and its variants, which includes the leukemic variant of MF known as Sézary syndrome, which we will discuss in the erythroderma episode. Together, this first group of MF and its variants make up 65% of CTCL cases. The second group of CTCL includes a spectrum of CD30-positive lymphoproliferative disorders, which include both lymphomatoid papulosis, also known as LYP, and cutaneous anaplastic large cell lymphoma. This second group comprises approximately 25% of CTCL cases. It's important to keep in mind that LYP in and of itself is not technically a lymphoma, but since it can progress to lymphoma in 10 to 20% of cases, some dermatology texts categorize it in the spectrum of CD30-positive lymphoproliferative disorders. The final 10% of CTCL cases land in the third group, which consists of a hodgepodge of rarely encountered CTCL cases. This group contains 8 types of CTCL, which I will mention in no particular order, and they include 1. Adult T-cell leukemia/lymphoma, which is associated with the HTLV virus. 2. Subcutaneous paniculitis-like T-cell lymphoma. 3. Extranodal NK/T-cell lymphoma nasal type. 4. Aggressive epidermotropic CD8-positive CTCL. 5. Cutaneous gamma delta T-cell lymphoma. 6. Cutaneous CD4-positive small/medium T-cell lymphoproliferative disorder. 7. Primary cutaneous acral CD8 T-cell lymphoma. And 8. Peripheral T-cell lymphoma. So again, the 3 main groups of CTCL are 1. MF and its variants, including Sézary syndrome, which consists of 65% of cases together. 2. The CD30 positive lymphoproliferative disorders, including LYP and cutaneous anaplastic large cell lymphoma, which together make up 25% of cases. And then 3, the hodgepodge CTCL group, as I call it, making up the remaining 10% of cases. And I'll spare you and not go over all those names again. There are certainly other ways to categorize CTCLs into indolent and malignant forms, but let's just stick with that basic look at it for now. So I'm sure your head may be spinning a little bit by this point, so let's quick summarize. While lymphomas typically start in the lymph nodes, they can also start or be primary in the skin. There are 2 types of primary cutaneous lymphomas, which are technically non-Hodgkin's lymphomas. 80% are cutaneous T-cell lymphomas, aka CTCL, and 20% are cutaneous B-cell lymphomas, aka CBCL. Today's episode will focus on the most common type of CTCL, Mycosis Fungoides, which is a papulosquamous disorder that mimics psoriasis. Thus, we place it in the psoriasiform category of papulosquamous disorders. Mycosis fungoides is an uncommon condition that typically starts in patients' 50s and 60s, but may occur at younger ages. The incidence is approximately 1 per 300,000 people, with approximately 1,500 new cases per year in the U.S. MF consists of slowly progressive lesions that have 3 stages: patch, plaque, and tumor stages. It is important to remember that not all lesions progress to later stages, and they can uncommonly skip a stage and present as plaques, for example. So let's briefly discuss the clinical appearance of each stage. Patch stage MF presents as round or oval patches, usually 1 to 5 centimeters in width, that may be annular or polycyclic. They may be itchy and classically appear on sun-protected areas such as the upper thighs or buttocks region. The appearance on sun-protected areas, or what we call the swimming suit distribution, is a nice pearl to remember because UV therapy is also used to treat MF, so it makes sense that lesions appear in areas that aren't seeing the sun. After patch stage, we have plaque stage MF, which presents as well-demarcated, indurated, scaly plaques that have a variety of shapes and have a violaceous or red-brown color. Tumor stage MF consists of rapidly enlarging nodules that develop within patches or within plaques of MF. These tumor stage MF lesions can ulcerate at later stages. There are also several variants of MF that aren't really psoriasiform, but I will mention them for completeness' sake. There is a folliculotropic variant which causes 10% of all MF cases and typically appears as papules and plaques centered on the hair follicles on the head and neck region, and they can sometimes be associated with alopecia.
Pagetoid reticulosis is an MF variant that has 2 types. 1. Warringer-Kollop disease, spelled Worringer-Kollop, Warringer-Kollop disease,
consisting of solitary psoriasiform plaques on the distal extremity, having a good prognosis, whereas there's a second variant of pagetoid reticulosis known as the Ketron-Goodman pagetoid reticulosis, and that's a more disseminated form. Some other MF variants include granulomatous slack skin MF, which is an extremely rare form causing sagging skin in the axilla or groin. And then there is a poikiloderma variant of MF that contains the 3 hallmarks of poikiloderma. And that's going to be atrophy, mottled hyper and hypopigmentation, and telangiectasias. Hypopigmented MF variants are the most common form of MF in African American patients and adolescents that get MF. Interstitial MF resembles granuloma annulare, and then there are a variety of other morphologies of MF, including verrucous MF, hyperkeratotic MF, vesicular, bullous, or even pustular MF variants. So let's put some of this knowledge to work and imagine you're on rotation with Dr. Grumpypants. So you're seeing a young patient with classic plaque psoriasis affecting the patient's scalp, elbows, sacrum, upper thighs, even affecting the patient's fingernails when Dr. Grumpypants asks you,
Take a break from dreaming about the length of your man bun and tell me this. What else should you think about when you see psoriasis in a sun-covered area?
So you correctly answer Mycosis fungoides, and later outside the room, Dr. Grumpypants asks you to briefly summarize how Mycosis fungoides presents clinically.
Okay, that was an easy one. Now you'll briefly summarize how Mycosis fungoides presents clinically.
So you confidently respond by saying, Mycosis fungoides is the most common type of CTCL and typically presents in patients' 50s and 60s as an erythematous, occasionally pruritic, scaly patch in sun-protected bathing suit distribution. It classically takes on a slow progression through patch, plaque, and tumor stages, although it doesn't always progress and it may present in the plaque stage.
Okay, so you know a few rudimentary facts about Mycosis fungoides? Is that all you've got?
There are several variants of MF, which include the folliculotropic variant, pagetoid reticulosis consisting of Warringer Collip disease, or the Ketron-Goodman variant, granulomatous slack skin, and a variety of presentations which include poikilodermis MF, hypopigmented MF, interstitial, verrucous, vesicular, bullous, or even pustular variants of MF. Dr. Grumpypants replies,
I see you still have much to learn.
Later in the afternoon, you're seeing patients on your own and presenting them to Dr. Grumpypants. You're doing a skin check on a 55-year-old, otherwise healthy guy when he points out an erythematous, scaly plaque that's been on his right lower butt cheek, extending onto his thigh that's been there for over a year, he says, and it's itchy on occasion. So what do? As always, you start by getting a good history of the lesion, going over your OPQRSTs, making sure to confirm the time of onset, any previous episodes of similar rashes, the progression since it started, and a good review of symptoms including fever, chills, night sweats, unintended weight loss, etc. All of this is negative for this patient. You decide to do a KOH prep, since everything that scales should be scraped to rule out tinea. After scraping the lesion, you also do a quick, thorough lymph node exam, since Mycosis fungoides is in the back of your mind, and clinically, lymph node involvement is very important for staging. The KOH comes back negative, but Dr. Grumpypants decides to treat the patient as tinea anyways, and he gives him ketoconazole cream twice a day, and he's going to have the patient follow up in 2 weeks. So you nod along, but in the back of your head, you have a feeling that this dude has MF. So what is the next step in diagnosis for this patient? A biopsy will likely be done next if he doesn't improve with the ketoconazole. So let's talk a little bit more about the histo findings and further workup needed. It's important to remember that MF often needs multiple biopsies to reach a definitive diagnosis. Some say it takes 7 biopsies over the course of 7 years on average. If your clinical suspicion for a lesion is high, don't be afraid to repeat the biopsy. But what will the biopsy show for Mycosis fungoides? For patch stage, we see a band-like distribution of lymphocytes at the dermo-epidermal junction, also known as the DEJ, and that's going to simulate a vacuolar interface, with a key finding being epidermotropism.
Oh, epidermotropism. Not bad. Do you know what that means? Or are you too busy thinking about how tight your next pair of pants are going to be?
Epidermotropism means there are atypical lymphocytes that are present in the epidermis where they shouldn't be, and they have a minimal amount of spongiosis to go with it. This contrasts with the term exocytosis, where there are lymphs in the epidermis with spongiosis. So since epidermotropism is a key finding in MF, it's important to do a broad shave biopsy rather than a punch, because you want to give your pathologist as much epidermis as you can to capture the epidermotropism. Besides epidermotropic lymphocytes, MF will also have atypical lymphocytes with large, hyperchromatic nuclei that can appear in clusters in the epidermis, known as Pautrier's microabscesses. In addition, papillary dermal fibrosis can be present as well. So in plaque stage MF, lesions have similar histo findings to patch stage, except that there is a more dense, band-like infiltrate in the upper dermis and more prominent epidermotropism. When there's tumor stage MF, there's going to be a further increase in the depth and the density of the atypical lymphocytes. But it's important to remember that the epidermotropism that was present in the patch and plaque stage may be diminished or absent in the tumor stage MF lesions. Besides reporting the H&E findings, your dermatopathologist will likely perform immunohistochemistry studies on the slide to look at CD staining. The typical phenotype for MF cells is CD3 positive, CD4 positive, CD8 negative, and CD30 negative. Again, that's CD3 positive, 4 positive, 8 negative, 30 negative. Now remember that the hypopigmented variant of MF that favors children and darkly pigmented patients has a cytotoxic phenotype that's going to be CD4 negative and CD8 positive. It's also important to know that the ratio of CD4 to CD8 cells increases as Mycosis Fungoides progresses. So there's more CD4 cells relative to a low number of CD8 cells in MF. A CD4 to CD8 ratio of less than 4:1 signifies less progression and thus has a longer survival, whereas Sézary syndrome has a CD4 to CD8 ratio of greater than 10.
As a reference, a CD4 to CD8 ratio is normally about 1:1 in most inflammatory conditions.
So, besides this ratio and the classic MF phenotype of CD3 positive, CD4 positive, CD8 negative, and CD30 negative, there can also be loss of T-cell markers, with loss of CD7 being the most common but least specific change, whereas loss of CD5 and CD2 are less common but more specific. The dermatopathologist can also perform T-cell receptor gene rearrangements to look for clonality. This clonality of lymphocytes can be suggestive of a diagnosis of MF, but it's important to remember that clonality may also be present in a variety of inflammatory skin conditions, such as pleva, lichen sclerosus, and lichen planus. So let's say you're back in clinic with the man himself, Dr. Grumpypants. It's 2 weeks later, and that patient has returned that you thought had MF. The patient says the rash isn't much better with the ketoconazole cream, so Dr. Grumpypants decides to take a couple more broad shave biopsies. He then asks you,
If this is in fact patch stage MF, what then will the biopsy show?
So you reply with your head held high that there will be a band-like infiltrate of atypical lymphocytes at the DEJ. There will be epidermotropism of these lymphocytes into the epidermis. It's not as much epidermotropism as you'd expect for plaque stage, but actually there is more epidermotropism in patch stage than what you see in tumor stage MF. In this patient, some of these atypical lymphs cluster into Pautrier's microabscesses in the epidermis, and you may also see papillary dermal fibrosis.
And then Dr. Grumpypants looks at you and says,
Go on, your minimalistic approach to academic dermatology has not caused me to lose my mind just yet.
Okay, so if immunohistostaining is done, you expect the cells to be CD3 positive, CD4 positive, CD8 negative, and you have a loss of CD7 staining with a possible loss of staining in CD2 or CD5. If these histo findings aren't definitive, which they often aren't for patch stage MF, then T-cell rearrangement studies can be done to look for clonality, which is going to be suggestive of the diagnosis. Boomtown once again. Dr. Grumpypants responds, as he always does,
Oh, I see you have not yet read any pathology, or biology, or biochemistry, or pharmacology, or dermatology for that matter. But you're not the worst I've seen. You may go.
So you're on the last day of your rotation and the patient comes back for biopsy results. And what do you know? It's patch stage MF and you were right. Dr. Grumpypants asks you,
Well, since you're such an expert so far, what do we do next?
Since you already listened to this podcast and did a little reading on your own, you tell him that patch and plaque stage MF without palpable lymphadenopathy does not need further staging workup, such as CT scans for lymph node involvement, lymph node biopsies, or any kind of lab work. So we can jump straight to treatment. Patch and plaque stage MF can be treated with skin-directed therapies, such as super potent topical steroids such as clobetasol, or topical nitrogen mustard, which is also known as mechlorethamine hydrochloride. These both lead to complete remissions approximately 60% of the time and are important adjuncts in advanced tumor stage MF as well. It is important to remember that a common side effect for nitrogen mustard treatment is allergic contact dermatitis, for which the medication should be stopped and the dermatitis is treated with topical steroids.
Other skin-directed treatments include topical retinoids and various phototherapies.
Narrowband UVB has a wavelength of 311 nanometers and can cause complete resolution in 75% of patch stage MF cases. Excimer laser has a wavelength of 308 nanometers in the UVB range and can be used for localized disease as well. Sorlin plus UVA, also known as PUVA, can also be used, and because it has a longer wavelength than UVB, it's going to penetrate deeper in the skin and treat deeper in the skin. Patients with patch or plaque stage MF can also be treated with radiation therapy, with a total dose of 10 to 36 grays in fractions of 1.5 to 2 grays that are given over 8 to 10 weeks. If lesions are refractory or progressive despite topical or UV treatments, more systemic treatments can be added. These include interferon alpha injections given subcutaneously 3 times weekly, or oral retinoids such as bexarotene. It's important to remember, bexarotene can cause central hypothyroidism and thus should be monitored and treated accordingly. For MF cases that are rapidly progressive or had lymph node or visceral involvement, chemotherapy can be used. One such regimen is known as CHOP therapy, with the C standing for cyclophosphamide, the H standing for hydroxydaunorubicin, also known as doxorubicin, the O standing for oncovin, aka vincristine, and P standing for prednisone.
Welcome back to Dermatographics. Today, we're in the Mike Fun karaoke bar to talk about Mycosis Fungoides, or MF. MF is a type of cutaneous T-cell lymphoma. The singer in a bathing suit signifies irregular erythematous scaly patches in non-sun exposed areas, also known as a bathing suit distribution. MF is typically itchy, hence her itchy arm. There are 3 stages of MF that we'll cover here: patch, plaque, and tumor stage. A flat rug will represent the patch stage, a chair, which is a little bit more elevated, will represent the plaque stage, and a booth, which is much larger, will represent the tumor stage. Let's start off with the flat rug in front of the stage, representing the patch stage, characterized by the presence of epidermotropic atypical lymphocytes. Just take a look at the singer raising the microphone in the air to represent how these lymphocytes are elevated in the epidermis. He's wearing a brain-shaped hat to illustrate the cerebriform appearance of hyperchromatic nuclei in MF. A pot of gold symbolizes Pautrier microabscesses, which are clusters of abnormal lymphocytes in the epidermis. The purple bands on his shirt represent a band-like infiltrate or lichenoid infiltration lined up at the DEJ. The singer is stuffing his mouth with a lime, symbolizing the histologic finding of a lymph in every hole, which is a clue to epidermotropism. These fibery wires on the stage signify wiry papillary dermal fibrosis, which is observed in the patch stage. Next up is the plaque stage, symbolized by the woman on the chair. Plaque stage MF has more pronounced epidermotropism, symbolized by this woman throwing the microphone up even higher into the air to symbolize more pronounced epidermotropism. The big bulky booth represents the tumor stage, which consists of rapidly enlarging nodules with frequent ulceration, symbolized by the ribbed seat. The mic drop signifies decreased or absent epidermotropism that's seen in tumor stage MF. A large quarter represents the large cell transformation, characterized by the presence of more than 25% of large cells, kind of like the large 25-cent quarter. The booth plays only the classic hits, with this CD from way back in the 30s indicating CD30 expression, a marker that's often positive in tumor stage MF. This sad child is refusing to listen to the CD from the 30s, symbolizing that CD30 may be negative, and he's sad to remind us that when CD30 is negative, it's associated with a poor prognosis. They take karaoke very seriously at this bar. Take a look at the strict rules for the singing teams. The sign for teams of only 3 and 4 indicates that the typical phenotype for MF is usually CD3 and CD4 positive. This other sign reminds us that larger groups of 7 and 8 are not allowed, which represents that CD7 and CD8 are typically negative in MF. A waitress with a T menu arranging a table symbolizes molecular testing for T cell receptor gene rearrangement, which is an important diagnostic tool in the early patch stage of MF, hence why she's far away from the tumor booth. Let's groove to the beat of some treatment options. On the right side of the graphic, by the rug and the chair, we'll go over the treatments for patch and plaque stage MF. A cooler isn't just for drinks here. It's our symbol for topical and intralesional corticosteroids. That's one chill MF. Even the mechanic came to party, reminding us that topical mechlorethamine can also be used in the early stages. He's holding a bottle of mustard representing topical nitrogen mustard, which can also be used. Check out these bricks. Man, they are taking team building exercises to another level. Bricks represent topical bexarotene. Think brixarotene, building up a defense against MF. We even got paparazzi here. The camera represents phototherapy, which can also be used in the early stages. Now, onto the treatment of tumor stage MF. At the booth, we've got a lineup that'll make your head spin, literally. This swirling vortex represents vorinostat. The Roman statue stands tall, symbolizing romidepsin, ready to conquer some karaoke. Vorinostat and romidepsin are both histone deacetylase inhibitors. This is shown by the histone-like arrangement in front of the statue, with the histone balls and the DNA ribbon. And hey, check out that waiter bent in a tux, symbolizing brentuximab. Last but not least, the patron sporting a MAGA hat represents mogamulizumab, which is another treatment that can be used in tumor stage MF. Let's wrap it up with a review of the symbols. The Mike Fun karaoke bar portrays Mycosis Fungoides, a cutaneous T-cell lymphoma. The singer in a bathing suit represents the hallmark erythematous scaly patches in a bathing suit distribution. The flat rug represents patch stage MF. The brain-shaped hat depicts the cerebriform appearance of hyperchromatic nuclei of the lymphocytes seen in patch stage MF, which are epidermotropic, as shown by the singer elevating the microphone. A pot of gold symbolizes Pautrier microabscesses within the epidermis. Purple bands on the singer's shirt illustrate the band-like infiltrates seen on histology. The singer has a line stuffed in his mouth to show the histological finding of a lymph in every hole, and fibery wires symbolize wiry papillary dermal fibrosis, which is also seen on histology of MF. The chair represents the plaque stage of MF with its heightened epidermotropism shown by throwing a mic up in the air. Moving to the tumor stage booth, the ripped seat is for ulceration, and the mic drop signifies decreased or absent epidermotropism. The large quarter represents large cell transformation, which is defined as over 25% of large lymphocytes, hence the 25 cents on the quarter. The CD from the 30s indicates CD30 expression, which is a positive marker in tumor stage MF. The sad child refusing to listen to that CD from the 30s reflects poor prognosis that's associated with CD30 negativity. The karaoke team limit of 3 and 4 symbolizes CD3 and CD4 positivity, which is the typical phenotype seen in MF. On the other side, no teams of 7 or 8 symbolize CD7 and CD8 are negative in MF. The waitress with a T menu rearranging the table reminds us of molecular testing for T-cell receptor gene rearrangements, which is a useful diagnostic tool. We go back to the rug and chair area for the treatment of patch and plaque stage MF. The cooler represents topical and intralesional corticosteroids, the mechanic for topical mechlorethamine, the bottle of mustard for topical nitrogen mustard, the bricks for bexarotene, and the paparazzi taking a photo representing phototherapy. For tumor stage treatments, vorinostat and romidepsin are histone deacetylase inhibitors that may be used to treat tumor stage MF. The waiter bent in a tux represents brentuximab, and the man with a MAGA hat represents mogamulizumab, also known as MOGA, also known as MAGA. Okay, that's all for now. In the next graphic, we head backstage to get to know some of the singers. So grab a bottle of nitrogen mustard and let's keep this party going. See you backstage.
Welcome backstage. This Dermatographics episode takes place backstage at the Mike Fun karaoke bar, where we get to meet the superstars that represent the variants of Mycosis Fungoides. At the center of our backstage mirror is a sign that reads Bright Side, illuminated by dazzling lights. The lights are so bright that you might even say they're hypopigmented. That's why they represent hypopigmented MF, characterized by areas of the skin that are lighter than the surrounding normal skin. They like to have big parties backstage, hence the party of 8 sign, which is here to represent that the hypopigmented variant is associated with a predominance of CD8 positive T cells, and it's usually CD4 negative. On the other side, a plant nestled in a pot, reminiscent of a hair follicle, represents folliculotropic MF. An old man is depicted sticking his head and neck into the plant, illustrating the condition's tendency to affect the head and neck area, resulting in papules, acneiform lesions, and plaques with alopecia, hence the balding hair on the man. The limes are falling onto the outer side of the pot, representing atypical lymphocytic infiltrates involving the follicular epithelium. The goo leaking outside the pot indicates follicular mucinosis. A deep, ominous hole behind the old man warns us of the increased depth of involvement in this variant, suggesting a more challenging treatment course and a worse prognosis. Next, our backstage pass brings us to a pageant queen for pagetoid reticulosis. In Dermatographics, we represent psoriasis with elbow and knee pads, and this pageant queen is decked out in elbow and knee pads to portray the psoriasiform plaques found on the extremities in pagetoid reticulosis. She's holding up a lime, emphasizing the prominent epidermotropism seen in this variant. She's giving a thumbs up, giving us reassurance about the good prognosis associated with pagetoid reticulosis. Lastly, the grandmother embodies granulomatous slack skin. Applying deodorant, she depicts the sagging skin folds often observed in the axilla or groin. Holding a giant gel cell of these multiple birds, she signifies the presence of multinucleated giant cells on histology. She's even eating a rubber band, drawing our attention to the prominent elastophagocytosis seen in granulomatous slack skin. Like most grandmas, she's slow-moving. You might even say that she's indolent, to symbolize the indolent or slow-growing nature of this condition. An owl perched on her head serves as a reminder that 30% of individuals with this condition may develop Hodgkin's lymphoma, which has owl's eye-shaped cells on histology. Our backstage passes at the Mike Fun karaoke bar allow us to meet the characters or the variants of Mycosis fungoides. The bright side sign reminds us of hypopigmented MF with distinct lighter patches. The party of 8 sign reminds us that this variant is CD8 positive. The plant in a pot representing a hair follicle represents folliculotropic MF, and the man sticking his head and neck inside the plant remind us that it most commonly affects the head and neck area. The limes on the pot remind us of the lymphocytic infiltrates involving the follicular epithelium, while the mucinous goo represents follicular mucinosis. The scary deep hole behind the man reminds us that increased depth of involvement is associated with a worse prognosis. The pageant queen in elbow and knee pads represents pagetoid reticulosis that has a psoriasiform appearance on the extremities. She is holding up a lime to represent prominent epidermotropism exhibited in pagetoid reticulosis. She is giving a thumbs up to remind us that it has a good prognosis. Finally, the grandma putting on deodorant represents granulomatous slack skin, which often affects the axilla and the groin. She is holding up a giant cell with multiple birds to remind us of the histological findings of giant cells that are multinucleated. Finally, she's eating rubber bands to show the presence of elastophagocytosis on histology.
All right, my friends, thanks so much for listening. If you want to support our content, please share episodes with a friend and leave a positive comment for us. Creating this content also takes significant expense, so any donations to help cover our costs can be made via PayPal or Venmo using the donation link on our website, grenzonederm.com. And that's with 2 Z's, grenzonederm.com. I want to share many thanks to our team that has made this content possible, including Drs. Karthik Krishnamurthy, Sean Schmieder, Dan Hyman, Kieran Smith, Jake Nelson, Elliot Lyles, Nate Marquin, and Elizabeth Ryder, along with my brother Garrett and Dan Thompson for their work with editing and post-production. Special shout out to DermNet and Cockrell Dermatopathology for their help with clinical and histology images, along with Dermatographix for their high-yield dermatology sketches. Okay, so that's the list for now. I'm Logan Kolb. Thanks so much for listening, and we'll see you next time here in the Grenz Zone.
This episode is copyright 2020 Pro Podcasting LLC, all rights reserved. The Grenz Zone podcast is a service provided by Pro Podcasting LLC and is not affiliated with any other service providers.